All right. Thanks, Ash. Thanks for everyone that helps us out with all of this. Thanks for all our sponsors. And a huge thanks tonight for Dr. McCarty for joining us. We just love this guy. I mean, Dr. McCarty, he's like the nicest. He's like the nicest guy you'd ever meet. Look at him. He's smiling right now. He's like always happy. He's just an incredible doctor, incredible friend to all of us. Thank you so much for joining us, Doc.
Oh, you're a good man, Rob. Thank you. Thanks for inviting me. This is really a treat for me to join you guys. You're all my friends. You're my colleagues. We work well together. We talk at conferences. I view the physical therapists, the athletic trainers, all those associated with what we do in sports medicine. It's all a big team, and you guys are part of the team. But it's a great world that we live in sports medicine, isn't it?
It's incredible. It's incredible.
Phil, we got a stadium filled up. My stadium's empty. You got a full stadium.
Your picture was pre-prime. I'm after prime.
That's right.
You're
Doc
exactly
Prime
right.
There.
Doc Prime. That's your new nickname, Doc Prime.
Doc Prime.
So, Eric, before we start, tell us a little bit about the excitement there. Tell us what you think of all that.
Oh, it is incredible. So, you guys Ashley actually got to see it firsthand, but last year we were 1-11, and that's a tough year, and everybody's down, and then Coach Deion Sanders comes in, Coach Prime, and re-energizes everything. I mean, he got a lot of people, and he came in and just brought his enthusiasm, his leadership, which I think I've been really observing it, and he's got some great leadership skills. And it's interesting. He just announced yesterday that he has a book coming out in March, and it's basically elevate and dominate, and 21 ways to win at what you're doing, something like that. And it'll be really good. I tell you what, I've enjoyed seeing how he handles himself and conducts himself with the team, with those around him, with those in the building, those in campus, those in the city of Boulder. He's really captured an audience of people that are just really fascinated with him and really interested in what he's doing. And it's got a lot of interest for the University of Colorado. I mean, we're selling out every single game. We're going to away stadiums and selling out places. Yeah. I mean, we're going to the Rose Bowl in 2 weeks, and they haven't sold out a game all year, but we're coming, and we're not the big team, but we got the big name, and that the Rose Bowl is already sold out for what they don't sell out the whole thing because they cut off some. But that just tells you the interest that they have with what Coach Prime is doing. So it's really it's been a lot of fun.
I think the last time Rob and I saw you, we were in Boston, and you were running off to catch a plane on Friday afternoon from Boston to Eugene, Oregon, which I think the stadium was probably sold out there as well.
Yeah, it was, but that's for another reason, because they're always sold out, right, Mike?
Yeah, okay.
Why'd you have to bring that up?
I had to get it in there somewhere with us.
That wasn't a great game, was it? That was a fantastic
Mike,
game.
If you unzip that little pullover, do you have an Oregon shirt on?
No, it's all you, man. It's all you. We support you because of all this. We've supported you all along, but I always like to rub it in a little bit.
Yeah.
But I didn't talk about the Stanford game.
No, yeah.
We've had some tough ones, but I do like what's
going forward. Positives,
positives, and that's
right.
That's what he really is a positive guy. So I think it's going to be fun to see what he does the rest of the season, but in years to come too.
I've been really impressed with the team and how you guys have come along in basically 1 year, as you sort of said, to be in for all practical purposes. Everybody has a bad day, but to be as competitive as the team is in a tough conference, that's pretty cool. You guys are doing good, and the recruiting's probably going crazy with kids. So
I bet.
A lot of good things. Good things.
And you guys have been there. You see what a beautiful place. But then if you get
it's incredible.
The engagement of a coach, and then all these the people that are interested, and kids want to come. So it's going to be fun as long as we can keep them around for a little while. I don't know how long that will be, but it'll be fun while we got them.
And we've got to keep quizzing you probably also, then we'll get into the articles, but we'll just have to quiz you weekly about who the rappers are in the locker room and the sideline. We know that's right up your alley, knowing who all those are.
I'll tell you what, it is crazy. I mean, I have no idea, like these names, and I'm looking around and they're on the sidelines, and I have no idea who they are. And I'm asking, I'm asking our athletic trainers, they don't know, and I'm asking, some of the other people, and some of these guys are rappers from the 80s or 90s, and some are recent. I don't know, but it is fun, and everybody's having a good time.
That's good.
Awesome. All right, well, let's start with the actual real show. Does that sound okay?
Yeah.
Eric, you played football at Colorado, right?
Yes, sir.
Yeah. So is that was it injuries that got you into wanting to do orthopedic surgery, or how did that all play out?
Rob, I think much of it was my interest in the human body. I was interested in medicine or the body as early as high school. Just interested in how you could train, the human body and make the muscles bigger and get in good shape. And then through high school and then in college, I did have some injuries and had to visit the orthopedic surgeon. Had surgery my first year in college, and so I had a red shirt that year. And through that process, at that time, you guys will appreciate this. It was 1983 and had an MCL injury and a meniscus. So they scoped the meniscus, and then they made a big open incision for the MCL. And now we probably just treat that MCL now operatively. And then I was in a cast for 1 month, and then a walking cast for another month. And so things have changed.
Locked in flexion? Were you locked in flexion for a little bit?
Locked in about 30 degrees of flexion for that first month. So things have changed, but my interest stemmed from those days and really was fascinated about how injuries occur and how you can help them and what you can do and the relationship that the orthopedic surgeon has with the team. And so that was my interest, was because of the background in football and playing at the University of Colorado for sure.
Nice. That's great. Well, we got three. You picked multiple articles, and we picked three of those. So we really probably should jump into those. So I think I've got these kind of ordered, I think, in maybe a good order, I hope. And the first one is the article on shoulder stabilization versus immobilization for the first time anterior shoulder dislocation. And so I guess my first question for you is just right off the bat, let's say you've got a first time dislocation in an active male athlete, just say he's a football player. It really doesn't matter what sport he's in, but do you treat him conservatively still, or do you go immediately to surgery?
I mean, I think there's so many factors that go into it, right? And this paper, brings forward the idea of considering arthroscopic or open Bankart stabilization for the first time dislocator, right? And it really is a very compelling argument for that. And I think this is part of the discussion we have with our athletes, whether they're at the collegiate level or even high school or otherwise, right? But that particularly that young athlete, and that's what this paper was. The average age was somewhere in the early 20s, but those are the ones that have a very high risk for recurrent dislocation and potentially then, having further injury. And so the discussion is good. If it's one of our football players, we have a discussion of, okay, here's what we can look at. Here's what we can do. As long as they don't have a lot of other injuries and they don't have any bone loss, discussion is, we can try and get you out there, rehab you, and let you play in a harness, but we're going to need to fix it at some point. It's easier for a freshman to look at this and say, let me just get it fixed. I got lots of years ahead. I'm not maybe playing much versus a senior who this is their last chance to play, and they let doc, let me just get out there. Let's try to play as much as I can. And then there's the guys that maybe they got other future aspirations and they don't want to risk it, and maybe they want to get it fixed. So there's a lot of discussion, but I'm not averse, and we certainly have that discussion, and I'm not averse to letting them play with a harness and getting back out there.
Yeah. This is a question I had, because I really didn't know the answers. I didn't think you usually have. If you have a first time dislocation, do you usually get a lot of bone loss with that, or is that? I thought it was after repetitive dislocations you start to wear away the front of the glenoid. Can that happen with just? I mean, if it's not with like a fracture, but can you have like significant bone loss from one dislocation?
And that would be a fracture. I mean, basically, so yes, you could have that glenoid fracture,
like a bony Bankart.
Yeah, bony Bankart, and that happens, and so you have to be cognizant of looking for that, because that's not something we like to let somebody keep playing with. Then, of course, what you alluded to was the repetitive dislocation or even subluxation, where you just keep coming out. The humeral head keeps coming out, and then start wearing down that front part of the glenoid, where it's more attritional type of bone loss, which can,
and that becomes significant. Yeah, that huge. In this study, they looked at the patient reported outcome measure that they primarily used was the WOSI. Is that what you normally use, Doc, or do you use others?
Yeah, it's interesting, and Sandy Kirkley, who is author on one of the papers that was included in that systematic review, fantastic researcher from Canada that unfortunately died at a young age in a plane crash. Absolutely fantastic. And then she came up with the Western Ontario Shoulder Instability Score, as well as the Western Ontario Rotator Cuff Score, and was really big in prospective outcomes. We're talking late 90s, early 2000s. So the WOSI is a really excellent one. Now, we just did another study looking at like a short WOSI, like 7 questions instead of, I think it's 21, which it can be more palpable for, or appeasing to appealing to people that don't want to do a long outcomes form, or maybe in follow-up. But we like the WOSI for sure. For shoulder instability, we think it's great. We also like the SANE score. I think everybody should at least have a SANE score. The single, number that hey, Rob, how's your shoulder? Give me a score. What's your shoulder score? Give me one number, 0 to 100. I think that's a very valuable way and simple. So we like the SANE, and then we also we like the ASES. But I think the WOSI was used in many of these studies that were used for the systematic review, because it is such a good, well thought out scoring system.
And it's specifically for instability, right? I mean, that's what it's mainly for.
The Western Ontario Shoulder Instability Score. Again, there's a WORC, or WORC, that's for rotator cuff. But this is specific for instability.
Yeah, good. The other thing I noticed with this study is that the protocols, so like the postoperative rehab protocols for this study, the different places, it was like they were all across the board. I mean, how does that affect, do you think, the ultimate outcome of patients? And it's not huge differences, but they're all just a little bit different in regard to time frames, when to start active motion, how long to mobilize, when to start strengthening, all of those things. They're not really consistent in the studies that they looked at. Does that affect anything really, or do you think I mean, they're different, but they're not different enough that it's going to make a huge difference?
I think that's a great point, right? Because there are some variability in how we treat patients post-op, whether it's a rotator cuff injury or shoulder instability. And you're right. All right. When do they start in motion? How much motion? When's active assisted? When is strength?
Exactly.
Right. Yeah. So I think it does make a difference, but I don't know if anybody knows what is the right protocol.
No, we don't know. That's it. Yeah.
I mean, maybe we need to study that a little bit better and figure that out. But I like to keep them in the sling for 6 weeks for the healing, but could they be in for 4 weeks? Could that be enough? Is it, I know that there's different ways to look at it, and there's different ways to approach it, and when to start more strengthening. I do think this, though, we do learn from our athletes, because sometimes they'll do things a little bit too soon. We don't think they should do it, and then actually they're fine. And then it's like, I'll get do that. But at the same time, you don't want your high school kid to think everything's fine and take off the sling in 2 weeks and then start playing basketball. They start stretching out everything. So, but yes, I think it matters. I just don't know the right answer, right?
Yeah. And if we knew the exact protocol that was best, we'd all be doing the same thing, right? And so there wouldn't be this variability. So it really just, I think, kind of alludes to us that we don't know what you said. We don't know what's best yet.
That's right.
Phil, Mike, do you want me to just dominate this, or do you guys have any questions for Doc? You want me to keep going?
Keep going. We got it.
Okay.
We got a lot to cover.
Yeah. Well, so the other thing about this study, Doc, they used the definition that they used, and they mentioned this, the definition for instability used redislocation, symptomatic subluxation, or instability episode. And so, that's kind of a large range of instability symptoms. Does that broad interpretation create some kind of issue with this, or is it okay for it to be that broad? Or
I mean, some of it's subjective from the patient, right? it's not very subjective when it dislocates. That's very objective.
Yeah.
So
Yeah.
there's some subjectivity to it, but that's how do you sense instability? Sometimes, people, hey, it feels like it slips, and did it really slip? And sometimes people feel that where it's like, it's stable. What are you feeling? Right.
Yeah, exactly.
So I think it's fair enough to look at it in terms of something like this, and you got to have some definition. And I think that, you got to have more than dislocation, because you can have instability without it dislocating.
Yeah,
And
yeah.
it's important for the purpose of the study to say, it's not everybody that redislocated. I mean, that's part of it.
They can still have, they can still be, it's still problematic for them, even if they feel like it's slipping. If they feel like it's loose, it's not dislocating, it's still problematic for them. They can't get back to their regular activities. Yeah. I thought the results of this were like huge. I mean, the recurrent instability was 35.7 in the stabilization group, 61.6 in the non-operative group. I mean, that's like double. I mean, it kind of points.
If you look at the whole cohort, though, I'm not sure. I think it was more like recurrent instability, and maybe remind me what you got those numbers for. The recurrent instability and stabilization group was like 6.3. And in the non-operative group was 46.6. So I mean, it's a huge difference, right?
Yeah.
And so I think, what you just said, 35%, I think was too much. But anyway, but yes, the difference is huge if you look at it, right? The difference that the first time stabilization versus non-operative, it's a big difference. Now, that being said, half of those people of the non-operative group did not have recurrent instability. So, okay, so you're looking at, you still got a chance to do okay with no surgery, but would you rather have a half a chance, or would you rather have 95% chance you're not going to come out again, or 94% chance? So
yeah,
I mean, it's one of those things, and that's that conversation with people too.
Have it constantly, don't you? Yeah. So last thing I have for this study, unless Phil and Mike have anything else, the range of motion on average that they looked at, they lost. So the range of motion of external and abduction was like 6 degrees. But I guess it was significant enough that they reported it, but it was 6 degrees. Is 6 degrees lost? Does that, in most people, do you think that amount is going to matter, or is it's probably player dependent, sport dependent, and position dependent, isn't it?
Yes, I would say so. And is it the dominant arm? Is it non-dominant? What's your sport? Exactly right. And some people don't like, even if it's 5, 10 degrees, they don't like having that loss of motion. Depends what motion that is, right? If it's abduction, external rotation, which is,
and they're a thrower,
a loss motion. But if you're a thrower, it's going to be different than if you're doing some other sport, where some people are fine, but that is one thing. We try to get your motion back, but I'm okay if somebody's a little bit tighter, and they're stable. And most people are okay, but some aren't. So
yeah,
I think it's really dependent on a lot of factors, and the patient itself, but also what they do, what kind of activity.
And don't you feel some of these? If they're not like old like me, and they dislocate and have it fixed, usually when they go back to whatever their sport is, they'll get some of that little bit that they lost back, won't they? Usually in time, don't you think?
Yeah, I do. I mean, it's like you start doing more and more things, and you're active, and you do tend to get more.
Get that back. Yeah. Okay. You guys got anything before we go to the next?
I just bring it back. We'll go back full circle. So Eric, if you had that player, and again, probably lots of variables I'm throwing out where Rob opened up with, that came in with that, has a first time dislocation, let's say it's mid-season, you still have this discussion with them like we just had, or would it be, and we're talking about the competitive person's division, Power 5 pro, do you try to take a non-operative and wait till the off season, or are you gonna talk about knowing these numbers go into a surgical repair?
Again, having the conversation, talking to them, looking at the MRI, is there a bony component? Are there other issues? What position do they play? Right.
Right.
So many things. How much, was it the first time dislocation? First time, okay, here's what you got. It's going to take a little bit for them to get back out, just to rehab it a little bit. And then again, it's a good conversation to have, because there are a number of variables, but I feel comfortable with them at least trying to get out there. In a harness, I do, we know that harness is not going to prevent everything, but it's going to help. And there's some proprioceptive benefit to it too. And so, it's something that, but I just had a freshman that I did surgery on yesterday. He's 18 years old, and, he did this, he was practicing with it. He's not feeling good. MRI showed, it wasn't, I don't know if he actually discoid, but he had a large Bankart lesion and a cartilage chip that was off and the Hill sacks. And I said, you're going to need surgery. You've been playing, you might want to do it sooner than later. And he's young, right? So,
Right.
Yeah.
There's so many factors that go into it. And like a high school kid, right? You got a 17-year-old, maybe he's never going to play football again. He loves high school football. Okay. That is a discussion with the parents, with him, and really just, okay, here's what we got. And if we can feel like we can be safe, even though we know there's a risk, that conversation can come through. And many kids just say, it's not worth to dislocate again. I hate how it feels. Let's just fix it. And, anyway, it's a great discussion. I think this paper, as a systematic review of the other papers, is helpful in our discussion with those type of young athletes.
Yeah.
And it sort of leads us in the next one. We didn't going off script here, Rob, but something that fits to this, because it could be from our non-operative approach, certainly comes in post-operative. But where are we today, Eric, with your thoughts on the immobilization process if we go down that road, internal rotation versus external rotation?
I think it's a really good question, and some of the studies have shown that external rotation can help, not as much as maybe stabilization surgery, which we actually had a systematic review on that too. I didn't necessarily put that one out there, but I think that if you really want to consider giving it a chance to have maybe a little more healing than normal sling immobilization, then putting the arm in external rotation for at least 3 weeks, that's going to be that external rotation out to the side and really getting it out there. The problem with that, and we tried to study this 15 years ago. I actually had a grant for it. I had multi-centers, and we were going to study it in the young population, is that they would not wear the sling once they started feeling better. You couldn't get them to wear it for 3 weeks. And so that was the big problem in that young population, that they start feeling good, and unless you almost like cast them in external rotation, or they get some way to really hold them to it, they wouldn't wear it, because they start feeling good after 5, 6, 7 days, and you really need to keep them in longer.
Yeah, that's tough.
Let's jump into the next one, Rob, and then we got some questions coming in from the audience. So go ahead and start the next one. We'll jump into that then.
All right, sounds good. So the second article is factors influencing surgeon's choice of procedure for anterior shoulder instability in the multi-center cohort. Was that you, Phil? What was that? That sounded like a lot of noise. Prospective cohort study. So first of all, this is the one you were on too, right, Eric? You were on this one with the Moon group.
Yeah, the Moon group. So
just tell us about the Moon group, and tell us the. I think it's great if you could just tell everybody the importance of that group and the value of being in that group and having something from them, and why it's important.
And it is. And so the Moon stands for the Multicenter Orthopedic Outcomes Network. Really started, the genesis was with Kurt Spindler at Vanderbilt with the knee ACL. So when I was with Kurt in practice, when I first got to know Mike, back in the early 2000s, when he's over at Belmont, was that we as a group there were a number of surgeons that decided through Kurt Spindler's vision to prospectively get information on ACL injuries and ACL tears. So this group of several surgeons, number of surgeons at about half dozen sites across the country, collectively decided what to take into account, how to prospectively get the outcomes and have the patients record outcomes. And so in 2003 started the first of the ACL. So subsequently, we knew this was going to be important for shoulder. And since I do probably more shoulder than knee, the Moon shoulder started out of that, and that subsequently, led by Jed Kuhn, who took my place at Vanderbilt, started this group of about 26 surgeons and growing at 10 sites across the country, which include anywhere from Ohio State to Iowa to Vanderbilt to HSS to Colorado, University of California, San Francisco, and others. But that group is a very cohesive, collaborative group that gets together. And one of the efforts that we've done some things on the rotator cuff and have published some non-operative literature on treating the rotator cuff tears. But this was an effort looking prospectively at instability, which has, we're going to have the largest database of prospective outcomes on shoulder instability, and this is through the Moon database, and so it's been great, and we've been doing this in the shoulder for more than 10 years.
Yeah, that's awesome. Well, we have if I look at our numbers of participants right now, we have like 116 people on this tonight. And my guess is, Doc, that probably not all of these people, not everyone on probably even knows for sure what a Latarjet or a remplissage is, and they're both discussed in this article. Can you just kind of briefly explain what those? I think most people know what the Bankart injury is, but I don't know that everybody knows what a Latarjet or remplissage is. Do you mind discussing those just briefly, what they are, as kind of a starting point?
Yeah, that's a great question, and because we have to have this discussion all the time with people, our patients, and others. And so the Bankart lesion, as we know, that basically you have a socket, and that tear of the labrum comes off the front part of the socket. Well, to treat that, you can do an arthroscopic repair of that tissue called a Bankart repair. We can add something to that. When the head ball comes out of the socket, it can create a little divot in the head ball, and that is called a Hill-Sachs lesion. And one of the things we can do to treat that Hill-Sachs lesion is called a remplissage, which is a French name to fill in. So that head ball that has a little defect, we can actually put anchors into that defect and take some of the infraspinatus and tie that into that, and acts as a tether. So it makes it harder for that humeral head to dislocate. So in addition to doing the Bankart repair, adding the remplissage can have some benefit, and more studies are showing the benefit of doing the remplissage, and particularly something I've been doing more and more, particularly in our high-risk athletes, such as our contact athletes. Now, the other question, or the Latarjet, which is from Dr. Latarjet in France, Latarjet, looks like Latarjet, but it's Latarjet, came up with this with others, but it was named after him by taking the coracoid bone and using that bone still attached with the conjoint tendon or the small head of the biceps, and taking that and then transferring that to the front part of the glenoid to give you more of a socket and more of a surface, so that the head ball had less chance of it dislocating. And that's fixed in there with either screws or buttons. There's a lot of different ways to do it. Now it's even being done arthroscopically, but the idea of that was to give more surface area for the humeral head and less chance of it jumping over the edge of the socket. So that's the Latarjet, and particularly we will do that for anybody that has bone loss in the front part of the socket. But it can be done even if you don't have bone loss. In fact, that was one of the original ways it was done in France. Was they just wanted a way to stabilize people, and traditionally that would be their go-to way instead of doing a Bankart.
So it was even done if they didn't have bone loss. It was done. They just put the extra piece on there just to make it larger.
That's exactly right. So they were doing it that way. In the States, we were doing a lot of Bankart repairs and arthroscopic stabilizations. And the Latarjet came over, and we started doing those, and the arthroscopic came over to them, and now there's been a good mix. But traditionally, Latarjet for almost every instability.
Yeah, I didn't know they did that without the bone loss. I thought it was always done with bone loss, not without. So that answered I was telling Mike before we started, I was telling him I came up with this brilliant procedure. Maybe you could do a Latarjet before they had bone loss. I thought it just exploded in my mind. I thought, wow, this is incredible. This is crap that I'm coming up with tonight. And now you tell me that they've been doing that all along. I had no idea.
The problem with that, Rob, is you're not French. If you've been French,
I know.
would have had something there. But obviously, because they're docs, we had.
That's right.
Yeah, they got a lot of instability there in France, I'm guessing.
Yes. So
Well, those
yeah,
are great. Those were great examples, Eric. Thank you very much. So the other thing I want you to explain, because I know people don't fully understand this, is the on track and off track lesion concept. I know that's confusing to people because I've had people ask me.
so simply, basically, so if we can look at the socket, and then if we take away part of the socket and you got a little less bone, and then you got that Hill-Sachs lesion in that head ball. And so if that head ball it has basically a large enough Hill-Sachs, and there's a smaller track for that to go on, it's easy for that head ball to come off the track of the glenoid and engage into a dislocation. So basically, it just describes how this head ball with this defect, if it's a large defect, and there's a lot of measurements. We won't go into all those measurements that can be done, but basically it's describing that ability of the Hill-Sachs lesion on the head ball to remain either on track, which means basically there's enough glenoid and the Hill-Sachs is not big enough to engage, versus a larger Hill-Sachs or a lot of bone loss, and makes it easier to become off the track and coming and dislocating. So on track just basically means that the Hill-Sachs with the glenoid, it seems to be not that much. There's still a risk. There's always a risk, but less of a risk than if you do these measurements where it's going to become easier. And again, the measurements have to do with the amount of bone loss of the glenoid and the size of the Hill-Sachs lesion.
So according to this study, like it's a huge rate of people now doing the ladder J. And if you have bone loss, that's like the procedure of choice, right? Is that, do you do it quite often?
Depending on how much bone loss. So I think as you look at it, and then that's what the study showed, you get above 20%, that was a big indication to do it. 11 to 20, maybe the preference in the surgeons may be more of open Bankart or remplissage, adding that to the Bankart. And I would probably be, looking at that. There's so many factors, and that's what we talked about. Like, okay, how long had they had instability? How many times did they come out of place? Had they had prior surgery, right? Because again, it's like so many things. Hey, if we did something the first time and maybe they have 5% bone loss, but we already did a Bankart, maybe next time we add something else, right? And do the remplissage with the arthroscopic Bankart. Maybe it's an open Bankart. Maybe it's the ladder J, even 5-10% of bone loss, but you've already had a surgery or multiple surgeries, but maybe you don't have too much bone loss, but you need something else. And so, there's a lot of factors, as you saw from that paper, that it was just gave an idea, like, what are the factors? And there's a lot of things that go into it.
Yeah. So what would you, if you had to say what the percentages of the different type of surgeries you do just across the board, are you still doing, do you do arthroscopic or open Bankart? What percentage do you think of that are you doing versus ladder J versus adding remplissage with a Bankart?
So I would say most of the stabilizations are done arthroscopically, and I'm doing a higher percentage of the remplissage, and that's probably based more on the size of the Hill-Sachs and how many episodes they've had of it dislocating and bone loss. And so arthroscopic Bankart with remplissage is maybe more commonly done for me than just the Bankart, because I've realized the value of that, and it really has been very beneficial, particularly my contact athletes and my younger athletes, which have a higher risk of coming out. Ladder J, I really reserve for the bone loss as we get above 15-20%, and maybe the revision that's 10-15%. They've already had maybe a couple of surgeries, maybe they already had a remplissage. So less ladder J, but that's definitely in what I do. I'm not doing it arthroscopically. I do think that there's some utility to doing either that or the bone block, arthroscopically. And I'm not doing open Bankart. To me, in my hands, the open Bankart doesn't add anything else that I can't do arthroscopically, especially with the remplissage. But some people really like it. I think they feel, and there's probably something to it, that they can create a lot of scar tissue by doing an open procedure.
Yeah.
But I think, you know, in my hands, I can see everything. I can tighten up everything. And by doing this, I do my surgery in the lateral decubus position. I can see 100 or 360 degrees around the shoulder and able to put a lot of anchors all around the shoulder and tighten even the posterior capsule up, even if it's an anterior dislocation. You know, we will still put some tissue and bunch it up and placate it, even if there's not a tear in that part of the shoulder.
Yeah, just try to stabilize a little more. Great.
Yeah.
We have Doc. I don't know if you know Amy Seitz. Mike and Phil both know her. She's a fantastic therapist, wonderful researcher. She was with us just a while back when we were at OSET. She has a question. In the Moon study, and thank you, Amy, for joining us tonight. In the Moon study and systematic review, both used immobilization as a comparator group label. Can you tell us more about this choice? We appreciate your perspective. Thanks, Doc.
You know, the label. So I guess label meaning they're in a sling. I'm not sure if I understand her question.
I think it's just in the titles they continually use I guess the second article didn't have immobilization, but the first one was shoulder stabilization versus immobilization for first time shoulder dislocation. Yeah. So the thought process of using the term immobilization
it just basically means sling use. So you could use the term sling, right? You know, if you wanted to, first time dislocation surgery versus sling, you know,
okay.
Or nothing, right? Because how do you control sometimes for that sling? You know, like I said, you know, it's a hard time, you know, doing it for 3 weeks if you're doing external rotation, and it's hard to control sometimes. These were prospective randomized studies that we used, and they did have a protocol for the sling use. And I honestly can't remember, you know, what period of time they used the sling. 4 studies used internal rotation or just a simple sling, and 1 study used the external rotation. But sounds like I need to meet Amy, and I'm sorry I didn't.
Oh yeah,
for sure.
No, I'm sure you will. She's fantastic. She's really great. We have a couple other questions here. One from Judith Talmo. Treatment protocol after surgery dependent on I think she's asking, is the treatment and protocol after surgery dependent on any to do at all with the type of patient?
Yeah, I would say for sure. You know,
can you give us examples of what?
So, you know, I mean, we all have them. Some that you know, absolutely, they're going to not do anything,
not follow any guidelines. Yeah,
and we're going to have to just keep it slow, and make sure that they're very well monitored, getting them in PT twice a week, and more frequent follow-ups with the doc, and just keep the hands on them. And so that's going to be a little bit different than some we know that we can see them once a week, and I can see them maybe once after surgery, maybe 6 weeks later, or right when they get out of the sling. And then some that you know that they tend to scar up, that you're going to have to move them a little bit sooner. And then others, exactly, a little multi-directional, maybe they have a Baton score of 7 or 8, you know, really hyper lax, and that you really want to go slow. You don't want to push that. Let them scar in, right? Let their tissue scar in, because they are hypermobile. We're not so worried about the motion. So I think, yeah, there's so many variables that go in that.
Yeah, that's what I was going to throw at you, Eric. The ones with the hypermobiles. I mean, definitely got to slow those people down.
Yeah.
They get it back. They get it back usually pretty easy. Okay, another question here on the question and answer here. Barb, I think it's Palace. With a ladder J, what is the goal of ER with PT? With physical therapy, I assume this motion is restricted with the procedure.
You know, it's interesting. Our goal is going to be full external rotation. You know, obviously, like any of these stabilizations, you know, we're not going to push a lot of external rotation at the beginning, but the goal is to gain it. And surprisingly, especially with a subscapularis split, where we split the subscapularis when we do the ladder J, instead of taking the subscapularis off, you know, you're keeping that intact. So you're not worried about the subscapularis healing like you would if you take it off and then repair it. And so I think that, and it's really interesting. I think you saw in the paper that there was a number of people would do it with the subscapularis split versus a tenotomy. And I prefer the split. And so, but to answer the question, the goal is to gain full motion, with that. And I think you can actually do that a little bit sooner with the Latarjet than you can just our arthroscopic Bankart. And that's because you're doing this bony procedure, you're not taken down or off the subscapularis, and you can work on some of that, but that's not something we emphasize early on.
Good. Bill, Mike, you got anything before we go to the third paper?
Let's roll on. Bill's dehydrated. He's on that. He spent that afternoon finishing up that 2 million today. That's why he's smiling.
Well, he may be smiling because there's something else other than water in his jug that he's drinking from.
It is from Baton Rouge.
Yeah. All right, last paper.
Dr. McCarty, don't listen to them. I've never met you. They've talked great about you. They didn't even introduce me to you. This is how great friends they are. But it's an honor to meet you. I don't have any Colorado gear like these other three do. I'm just a fan of you. I'm just glad to be here. I'm just absorbing it all. So thank you for that.
Well, I love it, man. That's great friends. They just put you on. They don't even introduce you. How about that? So it's.
Well, I was going to introduce him, Doc. I was going to introduce him, but we were just so excited about getting you on and getting going. We just let him just kind of sit to the side today.
In all seriousness, Doc, he's in Baton Rouge, but he works at Tulane with Buddy Savoie. They're good buddies and work together. So he was on last month with him. So.
Works with one of the best. So, man, Phil, what a pleasure. And tell Buddy hello. You got a great place there. So that's wonderful.
Can't wait to meet you in person.
Look forward to it too, Bill.
Good.
All right. So our last paper, guys. Our last paper. Are patients who undergo the Latarjet procedure ready to return to play at 6 months? Okay. What do you think of that?
It's interesting because, we're trying. This was, from our data from the Moon Group and trying to be a little more objective with things, right? Here's what's interesting. The French, or many of the French, will say, oh, yeah, you can just play at 3 or 4 months, and it's like, I haven't seen, and there may be something out there. Maybe you guys can help me out. Has there been any kind of rehab paper, with the Latarjet or with the French? But they'll often, bones healed, let them go. But I haven't seen any objective data like what we were trying to do. Strength. I mean, the main ones on this one were strength, range of motion, and well, do you need that to return to play? Well, yeah, it'd be nice, right? But there's more than that, right? And ours was pretty simple, right? It was looking at range of motion and strength, but there are a lot more to it. And I know that Mike and I talked about that years ago. Looking at some of the proprioceptive things, some of the ways to measure. Coming back from a shoulder surgery, and we're still learning on return to play criteria for that. And we didn't do any of the tests that are good, the kinetic, closed chain kinetic tests, the different ball drop or any of that. This was just purely, all right, strength and range of motion. And so my thoughts on it are that, I think there's a lot of people that are ready for return to play even before they get to those points, but we like to use those measurements. And I think it's important, and we probably don't do a very good job of utilizing, more objective data as we look at return to play, especially whether it's just a stabilization or Latarjet.
I think so. The other thing here is like looking at, as far as your range of motion goes, you were talking about, you want it to be full, but do you get full range with everybody after the Latarjet? It's typically, isn't it typically a little bit tighter after it? I mean, you want it to be tighter.
Yeah, sometimes it is, and sometimes it's absolutely fabulous. They get the full range and it's absolutely terrific. And
so
that's our goal.
Was that a byproduct? Do you think that's a byproduct of the rehab you're doing? Because we'll sort of talk about that because some don't. I'm just wondering what the variable is that on the success for that range of motion.
Yeah, I don't know. That's a good question. And I don't know. I can't remember if we broke it down to, hey, did they have the subscapularis split or a tenotomy, where they take off the subscap? Therefore, maybe that gets a little more scar tissue if you have to repair the subscap. And that brings another, questions that is there going to be any decreased strength or atrophy if you do something like that to the subscap? I know it's been suggested in the past. And so we try to really minimize that damage to it. Could that be part of it. And some of us, and myself included, I actually will repair the labrum and capsule and do some capsule orthopedy with the Latarjet. Some don't. Some just, kind of leave it and just leave the bone and maybe tie a little bit of the CA ligament that's still there to the capsule. And so I think there's some variability in even how the Latarjet and that the other parts around the Latarjet are done.
Yeah, I think that's a good point you brought up, Doc, about whether they actually took down the subscap or where they split it. Because I think some of the previous literature, I mean, I don't know how long have you guys been splitting it? Because I think the previous literature has been maybe looking at Latarjet where they actually take it down. And I think you're right. There's probably more scarring. There's more problem. You've got your have immobilization longer. And I think in a lot of those earlier studies, there was some loss of motion that was maybe problematic, but it may be simply because of that. So if you did the same studies that they did previously looking at range of motion loss, and you did it with the split, you might not even see it. I mean, range of motion may be okay if you can start moving them sooner, right?
Yeah, I think so. You can move these sooner, and again, letting the bone heal. It is a little bit different rehab, although I tend to do these very similar to how I'm doing arthroscopic. Let's get them moving, let's get some muscle going, but we don't want them to try to get full range of motion right away, right?
Yeah. So I guess there's when you do so if you do a Latarjet where you're taking a piece of bone and adding to it, it's really like an anatomical type of procedure. Is there just inevitably, is there going to be some decreased rate of return to sport, do you think, because it's such a big procedure? I mean, it's just it's like, is it inevitable that some people aren't able to go back?
Yeah. But that's even true with just our stabilizations.
You're right.
Too.
Yeah. Anything.
And ACL, right? I mean, we do a pretty good job, but even though they're stable, that some just don't get back. And is that because of the proprioception, Mike? Is that because of other reasons that
is it fear? Is it fear? Is it like psychosocial stuff? Yeah.
Part of it, right. And so, those are things that we still need to work out. So I think there's a lot of reasons, and not necessarily just because it was Latarjet or because it was a arthroscopic or open Bankart. There are a lot of factors.
Yeah, I think you answered this already. One of my questions was going to be is the problem with if there's a problem with motion loss, is it really more kind of because of the anatomy, or could we potentially be a little bit more aggressive with our range of motion? And you've kind of answered that. I think that maybe we could. I mean, and you're saying you let people. It sounded to me like you're saying compared to maybe years ago, you tend to move people a little bit faster even with this surgery.
Yeah, I think we probably could, and there's that fine line, right? And some that you probably really need to, and some that you probably don't need to or don't want to.
Yeah. And you're okay.
And I think we had a question here. It's perfect time on some of this, but this from one of our buddies, also from ICUS with Lance Gill and Titleist Golf Company. But Lance throws out the question to us: if you had any insight into patients who've undergone a Latarjet who are seeking return to golf. I don't know there'd really be an issue there, but see if somebody that requires full shoulder motion, particularly, I guess, would be a trail arm with external rotation going overhead. But you notice anything? I mean, obviously it's not a high risk sport for shoulder dislocation with golf, but there's a lot of people who have had the problems that want to go on to golf recreationally with that. So any insight at all or anything you might think about there?
I haven't really thought about that, because you're right. Most of the ones that are dislocating are not golfers, but there's a lot of people that do have instability that do like to play golf.
Right.
Subset that maybe I got to get one of my students to kind of look and see if, of these people that have had shoulder instability surgery, how many play golf? How did they do? And I honestly don't know the answer to that, right? I mean, I think it's a good question.
And usually, I guess, with the stuff we do, and Lance would jump in on and tell us, but I said it's not a high-risk sport. Obviously, golf, usually the people that have the injuries in golf, they're bringing those injuries to the game. So now they're going in, like PGA Tours going into their break. Ski season's coming up, or some of these guys will go to the resort snowboarding and dislocate a shoulder before next season. They're bringing it to the game. They're not acquiring it in the game. But I was just curious if there's any insight there.
I really don't have any. I mean, I think, like, again, our goal with any of this, is your guys' goal is too, that, we want to gain full motion, right? But we're okay being a little tight. Now, I would think, as you're golfing, maybe it affects you early on. Depends, again, which shoulder is it? But I think that's actually going to be some good rehab, right?
Yeah.
gain a little bit more of that motion, and maybe it helps correct the swing a little bit, get a little tighter. I don't know.
Slingshot. There we go.
There you go.
Slingshot.
Yeah, you got it.
Yeah.
Generate a little more force.
Yeah.
In this study, Dr. McCarty, the strength loss was only like 6%. So these people really gained their strength back pretty good. They described really the motion as being the biggest problem, and it's ER, obviously. So that brings up kind of the point we talked about earlier: is who is this affecting? Is it affecting a lineman who maybe doesn't need as much ER, or is it a baseball pitcher who maybe 6 degrees loss of ER, or not 6 degrees? We're not talking about degrees now, but a loss of ER for the baseball player is going to be huge, but for maybe a lineman, it's not. It's really patient dependent on how much
Really?
range of motion loss you can tolerate.
So, and this was, if you think about it, this was done in a 6-month time frame. We had different time. We weren't doing this every month, so we look at it, and this was at the 6 month, right? Well, where were they at 4 months? They may have been about the same at 4 months, and maybe that was adequate for them for where they were. Maybe they had the same kind of strength, at 4 months, at 5 months, at 6 months. But this was, we had time frames that we did it, and 6 months was when this was recorded. And yeah, there's gonna be a lot of athletes that are gonna be fine to do their sports with 20 degrees of extra rotation loss, right?
Yeah, they can tolerate it. Yeah,
going to be, they're not going to tolerate it at all. So I think there's a lot of variability that has to go into it, and a lot of factors that this paper would not even address. But it brings up a good point to think about, right? Okay, and I think the points that I like to think of is like, what are we testing? How are we testing it? When are we testing it? And what really matters? And that's not all answered here, but it brings up good thought process for sure.
No doubt. So I guess my last question on this paper was, when we talk about return to sport for people after this, because we've got different types of athletes that are having different types of surgeries, and it kind of sounded like you alluded to, I think, the fact that maybe the type of surgery does kind of have to consider the athlete and the sport. Should our return, so if we have just like this blanket return to sport criteria on range of motion and strength, and we have these set goals of what the range of motion and strength would be, those aren't going to fit everybody. So should our actually return to sport criteria, which we just set like a blanket statement, should the return to sport criteria actually be based on the sport or the position? Meaning a football lineman may have a different return to sport criteria they need to meet than a running back versus a basketball player versus a baseball pitcher versus a first baseman.
And men and women, Rob. Men versus
and men and women. Someone asked the question here on the question answer about, do you treat men different than women, that have these type of procedures? So should the return to sport, should we not have a blanket return to sport, Doc? Should we actually have them maybe more specific toward the actual type of sport and position the person plays in the sport? Because we even you were talking about ACL reconstructions. So we have a return to sport testing that we do for ACL people, whatever it may include, but it's all the same. But not everybody's the same, right? I mean, a long distance runner doing a return to sports totally different than a running back or a sprinter, right?
Yeah, I agree. No, that's a great point. And that's where maybe you start getting these algorithms and you start looking at artificial intelligence and start maybe kind of looking at this and saying, start plugging these different variables in.
Yeah.
I mean, we have soccer players that dislocate their shoulder. Well, I'm going to let a soccer player go back out there far before, right. I'm going to let my linebacker go out there. Right. And so, yes, the answer to your question is absolutely. There should be a way to look at it other than our judgment, which is a lot of gestalt and a lot of experience. And I'm sure that could be looked at in a way such as what you're talking about, upper extremity sports. What type of extremity? Which side is it? I mean, there's a lot of factors. I love the discussion though. It's really
these discussions are great. We have another question. I got to throw this one out there, Phil.
No.
Yeah, Yeah, this Peter, I love Peter Galt. I don't even know Peter Galt, I don't think, but I love him already because he
He's
said,
one
"Can
of
I
my
get Doc?"
students.
Oh, he is. Yes,
Yeah,
of course. Peter, I love you, man. I'll sign whatever you want. You send me a copy of the book and I'll sign it for you, free
well,
of
you're the
charge.
author. You should send them the book. The question was, can you get Dr. Mansky to autograph a copy of his textbook? I actually have one though.
All right, what do we got? We got one other question here from Patty. I see athletes injured kayaking who want to return. You probably see that, Eric. You got kayakers and stuff up there, right?
Whitewater,
When do you think I should feel comfortable talking to them about returning to the rivers?
yeah, I think, number one, they have to be stable, right? And have to have that sense of stability. And then with that, I think they have to be able to handle that repetitive motion of what they do, because that's actually can be a very dangerous thing. We see that. Same with climbers. We see these type of people that you got to have a stable shoulder. And I think that,
for sure.
it's really, you want to have good strength, endurance, and again, you want to make sure that they don't have that fear of coming out, because that's going to inhibit them from being out there. So
Eric, have you ever done climbing?
Yeah.
Oh, you have?
Yep.
Dude, I remember one of the times this was before I met you. I came to Boulder, and my wife and we walked up to the Flatirons, and just like at the base of them, and these guys were climbing that damn thing, and they're like way up there, and there's just no way in hell I would even try that. I mean, I'm not scared of heights, but I'm scared of falling off of a huge rock. So I don't think I could even do that. Voight, would you climb a huge rock like that?
No, but I tell you what, and it wasn't Eric or anybody on your team that saw this person, but I had a student show me one of her. This was this fall, just this past fall, is the dangest thing I ever saw, but fell off of that rock, so it wasn't free climbing, and landed and literally fractured their lower leg, but the talus shot out of the ankle like 20 feet away. I mean, the talus was laying on a rock. I mean, you couldn't hardly even see it, though. It was like a perfect, like a watermelon seed with this coming right out of the ankle. And the x-ray, you're looking at it going, geez, there's something missing here. And they showed the big picture. But no, I wouldn't do that.
No. So, well, ask Phil. He's Louisiana. Phil, would you do that?
Do that.
We don't have rocks over here.
Phil won't even get on the top of his house.
We're below sea level. We don't have rocks.
He doesn't hang Christmas lights.
No. Phil's scared of the roof on his house. What are you talking about?
So Rob, remember, I grew up in Boulder. So, I mean, as a kid, my dad wrote climbing books. I mean, he actually
you gotta be kidding me. I didn't know that.
So he put me up climbing all the time. So I've been up the Flatirons. I've been up and down them, and
wow.
I don't do that stuff now, but it was
but you have.
But I was protected. I wasn't doing this free solo type thing.
No way. I just get nervous even when I'm watching movies, like when they're, who was it Sylvester Stallone? Cliffhanger. Yeah, that just makes me nervous. I'm just like sweating watching the damn movie, and I know it's a movie. It's not even real. Dang.
Hey, we're all right. Time, but as we get close to the end here, I'll throw one more question out. I think it's a good ending question for tonight because lots of stuff. But Doc, what excites you about the future of shoulder surgery, or what's the next big thing as you see coming? I know you're always into research, and you're always a pioneer. What's exciting you about the future?
I think still understanding how we can treat shoulder instability with bone loss, with revision, and how biologically we can help things heal up, maybe a little bit sooner, maybe a little bit better. Biologics are a big thing in what we're doing in orthopedics, and I think in shoulder instability that's going to be part of it. And I still think we still got to do a better job trying to understand what we can do with rehab and the things we talked about 20 years ago, Mike. Right. I mean, the proprioception and understanding and how we can do that better and how we can test it and exactly the discussion we had tonight. I think, there's still a lot that we're learning and I'm excited about it. And it's an ongoing, thing that we are looking at and adding things like the remplissage, which has helped us provide more stability, more than just the Bankart. And so I think there's a lot of neat things that are still out there. We're still learning, and it's a very exciting field. I love shoulder instability, and I really appreciate you guys having me on. This is great. I'm just talking about things that we love to do and treat, and and
It's
great
fantastic.
guy,
Yeah.
and just a wonderful discussion, a lot of good questions that came up, and thank you again.
Yeah, well, it's fun
No.
talking to you because this is what people don't realize. This is what we get to do at meetings, and we're around you. We sit in the hallways. We almost make you miss flights or put you on one to Corvallis instead of Eugene, things like that. But it's what we get to talk about. So we really appreciate you working with us because you typify what we talk about, even now with football when you're talking about, but typify team and working together with us. Because we've learned a ton from you, and hopefully we can share a little bit back the other direction. But you're sort of a pioneer, and I know you're going to say that. Well, that just means you're old. You're not old. You're just a pioneer in what we're doing, and it's because you're asking those tough questions and doing it. And I didn't even want to open that door when you said about biologics, but you have a great team around you there with what you're doing at CU and all that. So I know there's great things coming out of the surgery or the sports medicine department there with you guys working. Plus, Coach Prime keeps you right there in the same building. You can't get away from him. You're in the stadium 24/7 with that reality show.
Oh my goodness, it is a reality show too, man. He's got cameras people with iPhones that are filming everything he does, cameras. Watch, if you're watching the game, watch when he walks on the field, how many cameras and just video is being taken of him. And it's really a phenomenon.
It is, yeah.
That's
It really
fascinating for you to observe. But I tell you, watching his leadership and just watching how he talks in the locker room, watch on the sideline how he talks to his guys and his players. He's not a real big yeller. Talks to him, brings him up, and looks at him and just teaches, instructs. It's a good lesson for all of us, and very encouraging. And but he's human, and things. There's things he doesn't like and things that get him angry. But he's a unique guy, one of the greatest athletes, and I've enjoyed every moment that I've
maybe
been.
a little bit rubs off on you, but I don't think it needs a lot because you're a great leader within our profession and what we do, and a teacher along the way with that. Because as I said, we've learned a ton from you along the way, clear back to our Vanderbilt days, where we asked a lot of questions there and still continue on, and really impressed with what you're doing.
Well, hey, thanks much. You guys are terrific, great friends. Phil, I got a new friend. You got to come. We got to get you up to Boulder too. And
Anytime, Doc.
I love it, man. You guys are great. So thank you for having me. And again, wonderful. It makes a great team, right? The therapist, the doc, the trainers, it doesn't have to be the orthopedic surgeon, the non-operative docs. Everybody, we all work together and helps get everybody back on the field and keep them on the field.
That's
so
the goal.
Thanks again.
That's the goal. Yeah. No,
Rob,
thank you,
Doc.
Doc.
Close it out, Rob. Take us home.
Yep. Well, thank everyone. Thank you everyone for joining us. Dr. McCarty, thank you so much for joining us. We have a schedule for November. I think is it 13th, Mike?
You've asked me that every day. For
I
about
know.
the last
I
2
think it's
weeks.
November 13th. It's around November 13th, maybe November 13th. I don't know for sure. It's the Wednesday at 6:30 p.m. Central, around the week before Thanksgiving.
15th, November
15th. Okay, see, I was off
You're
2 days.
close.
November 15th. And we don't know for sure who we have yet. We have several people kind of on the hook, but we haven't got it decided yet. But we'll shoot out emails to let everybody know as soon as we find out. All right.
Good luck with the rest of the season, Eric.
Yeah.
Thank you.
All right,
Appreciate
guys.
it.
All right.
Good
Thanks,
night,
guys.
everybody.
Have a good night, everybody.
Good night.